Hello and good evening. I'm Melissa Idris.
And I'm Sharad Kutil.
Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Last week, Health Minister Kari Jamaluddin announced that Malaysia will be moving away from COVID-19 pandemic state in management into an endemic phase management by the end of October. Now, what does that mean exactly? And are we ready? Some experts say it may be too early to move into an endemic phase and that to transition early might come with some risks. One of those experts joins us on the show today. Dr. Amar Singh is our guest. He's a senior consultant pediatrician retired from the Ministry of Health. You may have read one of his many articles on Malaysia's pandemic management, and you may recognize him also as one of the leading voices shaping the conversations around our public health strategies. Dr. Amar, it's a pleasure to have you on the show. Welcome.
Thank you very much, Melissa. Good to be here with you and Sharad.
Now, you've argued that Malaysia might only consider entering an endemic phase by January or February of 2022, and that October is too soon. I'm just wondering why you think October might be too soon for us to adopt an endemic approach. Can you elaborate as to how you come to that timeline?
Thank you. Yeah, that's a good question. I believe much of our discussion around the endemic phase is based on our vaccination rates. And currently, our vaccination rate is about 50% of the population. I think it's important to point out that we must always look at population vaccination rates and not adult vaccination rates, because that's what we really need. So Delta has changed the whole face of this pandemic, the whole face of how we think. In the past, we thought of herd immunity. Now with Delta, that seems to be actually quite elusive. So the models from a number of countries, especially Australia, show that even if you have 80% of your total population vaccinated, you actually cannot really stem a Delta wave in your community. You have a lot of deaths, your hospitals will be overrun. And they estimate that you need 90% of your entire community vaccinated before you can actually move to what we call this endemic phase. Or you can move to a phase where the health system can cope and we can go out and about as we did before. I think we recognize that about 30% of our population are children, number one. Number two, that another 20% of our adults have not been vaccinated yet. That we have a migrant population that we don't know the full size of. And lastly, there are also vaccine-hesitant individuals who haven't come really forward for vaccination. If you look very carefully at our vaccine curve, it peaked at the end of July, and actually it's been coming down since then. And that's the status in every country in the world. Your vaccination rates rise rapidly, and then you actually struggle. Once you go past 50, 60%, you actually struggle to mop up the rest of the population. So I believe that by early October, or probably, late September, we probably might reach 60%. That's assuming that we can maintain our vaccination. Then the next 3 months, we're going to have to work very hard. One, to work on children, teenagers 12 to 17, that's about 10%. And we hope that all of them take it up. You're not sure whether all parents will be keen to take that vaccination. And then we have to mop up the remaining. So I can't see even the end of the year that we have touched 80%. The target, of course, is that by mid-November, we reach 80%. But looking at the momentum that we have, I think it's probably going to be 80% by December. And whether we'll reach 90% by January or February, I think that's something that requires a lot of extra work. The last mile is always very difficult with vaccination.
Do you think that ultimately, we use the word endemic, and a lot of politicians and people in the media bandy the term about, but it's become actually a shorthand for the tough political decision that needs to be made, not solely on public health foundations, but on questions of the economy, of, say, education, schooling, and all these other dimensions of society that need to be in the mix. So it's not strictly about the issue of, complete vaccination of the population and so on and so forth.
Mm-hmm. Fine, thank you. Yes, I believe that two elements that we need to consider, two bottom lines, I think, in my mind. One bottom line is the health services. If we don't manage this well, the health services, as we know, have been severely overrun. And right now, the Klang Valley is just recovering, and we know 6 states out there are in a bad shape. So if we move to what we call endemic state, but without managing that adequately, then our health services are going to be overrun, and we're going to exhaust our resources, not just our manpower resources, but our ICU beds, and our mortality will go up again. But I recognize the second bottom line, which is critical, which is the economic bottom line to save lives and businesses, the school bottom line to get children back to school. But recognize that if we open schools right now, you're going to have a huge outbreak in children. This is seen in Norway, seen in US, and expected to be seen in UK right now, already seen in Scotland. So sometimes I haven't mentioned this in the press, but I think of the next Delta wave in Malaysia as the pediatric Delta wave, the children's Delta wave that's going to come if we open up too soon. So we may use the word endemic any way we like, but the realities are still going to be there on the ground. We actually cannot go back to school or open economy too quickly without protecting these individuals, especially children right now.
So are the danger of moving to an endemic phase too quickly, are children the category that you're saying is most at risk?
That's one category, Melissa, but there are other categories as well. Don't forget the people adults who are still not vaccinated. That's one group. Then we have people who don't do so well despite 2 doses of vaccination. We know that breakthrough is happening. I would say that the current estimation for AstraZeneca and Pfizer breakthrough is 1 in 3. That means 1 in 3 persons who has had 2 doses of vaccination is going to have a breakthrough. Most of them are going to be mild, but some of them are going to be severe. So if there's a large enough outbreak, then some of these individuals are going to become sick again, as we have seen in other countries. And the third group that I'm concerned about is our immune-compromised individuals, who are the ones who don't take very well with vaccines, and they are the ones who also will be at risk of a severe infection. But as a pediatrician, I would say children are the ones I'm concerned with. If you look carefully at the pediatric data overseas and locally, there are 2 peaks of severe infection. One is the teenagers, which are closer like the adult kind of picture. And then there's the 0 to 5. And that's a very, very difficult group to protect right now because there are no vaccines approved for their use anywhere, in the industrialized world. So I anticipate if we have a large outbreak, 1 in 10 children will get long COVID, 1 in 100 will get admitted, and 1 in 10,000 will die. And I'm very conservative with those figures. Those are the minimum figures I would put out. The real numbers are probably higher than that.
Amar, we do have many diseases, and we accept that death is an inevitability for some of those diseases. Is that going to have to be the case with COVID as well?
I believe that it will be okay if we move to an influenza-like situation, where we're all familiar with influenza. We know some people, we all might get it, every once in a while. I've had a couple of influenza. I've been hit a couple of times. It knocks you off. You might get off work. You feel rotten. You need some tender living care, and then you recover and you go back to work. You may have some lingering symptoms for a while, but a couple of people, those with heart diseases, lung diseases, some small children, some elderly die or get severely infected. So if it comes to that kind of a situation where the majority just gets some illness and recover, and the minority gets severe illness, then I think the health system can cope to support that smaller group of people. So it's the size of the problem, I think, Sharad, that we are thinking of.
Right. Dr. Amar, I just wanted to check in with you. I mean, when we talk about an endemic phase, how do we think about what the benchmarks should be? I mean, it will be completely different from how we've conditioned ourselves to think for the past, 18 months or so, particularly in terms of what numbers to watch, what metrics to look at, how to evaluate risk in society. What are your thoughts on that?
I believe that this is a very different virus from the conventional ones we are seeing in some sense. In the past, when you vaccinate someone against a major disease, majority of them don't get infected. So this is behaving a lot more, like the influenza kind of thing. You can be vaccinated and still get infected by the condition. So I think with the kind of breakthrough rates I was quoting just now, which, by the way, may be higher with Sinovac. We don't have good data for Sinovac yet. We can't use case numbers anymore. I believe once we have vaccinated the states outside KL and reach more than 50, 60%, we have to move away from looking at case numbers to looking at severity. And what is severity? Category 3, that you got pneumonia. Category 4, you need oxygen. Category 5, you need a ventilation or respiratory support. Plus another one, which is death. So I believe the metric we're going to have to use to monitor this kind of a pandemic is severity of illness. And not just severity of illness, but perhaps severity of illness tied to their vaccination status, type of vaccine, and of course, where they're located. I've been very worried during the Klang Valley outbreak that a lot of people were managed outside the ICU. So I think that must be a factor in our evaluation of this. That gives a health service capacity coping of the pandemic. But for the public, they should know severity of illness more than number of cases. For example, let's take an electoral example. For Sarawak right now, I'm not looking at their cases. The cases have spiraled out, seem to spiral out of control, but a lot of that is breakthrough with milder infections. The ones we should look at is hospitalization and ICU usage.
Very quickly then, before we go to the break, are you hopeful that not just the development of better vaccines, but also therapeutic drugs? There's a lot of talk about drugs being trialed that inhibit the development of the disease in an individual who's been infected.
Yes, I am. I believe never before has this volume of money or research or resources being put to look at one disease. I think if we did this for any other disease in the world, we might have eradicated it by now. So I believe that's wonderful. I do believe we will come to a coronavirus vaccine at some point, a vaccine that covers many coronavirus. I do believe that we'll find better antiviral drugs that treat people who are severely ill. But the drug medication, I don't think it's going to be a preventative issue. It's going to be a curative issue. So you're ill, we then offer this to treat you, to minimize you getting more severe, or if you're severe, we minimize you from reducing your risk of death. But that's where I place the drugs. I don't think the drugs are something you and I are going to be popping every day to prevent coronavirus. For that, I think we need to work towards getting a pan-coronavirus vaccine, which many individuals are working on, which actually might be nasal or even oral for that matter.
Okay, well, we're going to take a quick break, Amar, but then after this, I want to come back and touch on that, on the vaccination strategy till we get this vaccine that you're talking about. We might have to make do with what we already have. So let's come back and talk a little bit about how we may need to reconsider our strategies going forward. We'll be right back in just a couple of minutes. Stay tuned to Consider This. Hi, welcome back to Consider This. I'm Melissa Idris, with me Sharad Kutin, and we're speaking to Dr. Amar Singh, Senior Consultant Pediatrician. He's also retired from Ministry of Health. We're discussing the decision or the announcement made by Health Minister Kari Jamaluddin that Malaysia will be moving to an endemic phase of the way we manage COVID-19 by the end of October. Dr. Amar, just before the break, we were talking a little bit about vaccination strategy, and I do want to touch on something you said about breakthrough infections, right? So we know that breakthrough infections can happen, but it's likely to be not so severe symptoms. But is there a need to rethink our strategies? I mean, there's been so much said about boosters, about mix and match strategies, about spacing the dose interval. What are your thoughts on how we should be perhaps thinking about vaccine strategies moving forward?
I believe that, we really need a good expert committee of virologists and other individuals, who can advise us, or we can look hard at the data of what other people are doing. Some countries have jumped in and given a booster. Some countries giving it to people above 60. Some even doing it above 40. But I think we should divide this into two groups of individuals. One, we don't talk booster, we talk third dose. Some vaccines in a 3-dose schedule. So I believe that there's very good data right now that we need a 3-dose schedule for anybody who's immune compromised. The problem is identifying all of these. This will require their own physician or doctor who knows them. And for people who suspect they may be immune compromised, to actually come forward and say, hey, can you make a decision whether I need a booster or not a booster, a third dose or not? So let's not call that a booster. Let's call it a third dose schedule required for people who don't mount a sufficient immune response. The second is this issue of a booster. And a lot of people are actually making a push, even in our country, for boosting, and they are keen to boost healthcare professionals. They're keen to boost older people. Now, these are the two groups that we should consider. One, people above 60, because that's where the immunity may not be so good. And secondly, not just healthcare professionals, I put all frontliners. I would put police officers there. I'll put people who sell our food to us. I'll put the people in supermarkets, the ones, because it's the highest exposure people. They're the ones who get exposed to lots of individuals, and their risk of getting reinfected is the highest. I must say right now for Pfizer and AstraZeneca, the data is not there. Definitely for AstraZeneca, it's a tahan lama vaccine. The immunity seems to last very long. For Pfizer, there is some data for waning, but not enough to actually say boost or not boost yet. I think we have to watch a bit further. And most of our health staff actually got Pfizer. The group that I'm most worried about, the one who got Sinovac, I think that's where we must look hardest at the data, and I'm hoping that Sarawak will give us the answer, because they had almost 80%, 79% had Sinovac, and they can give the answers to the rest of the country with good data. I understand that Unimas and other colleagues there are working to help answer this question, because we're not going to get this question from outside our country. So that's one place we must get a fast answer for, because Sinovac seems the one where, Thailand has started boosting, Indonesia started boosting because they use a lot of Sinovac there. I want to say that, it doesn't mean we don't need boosters. I just believe that we should, right now, mop up all the other adults, settle our children, and then come back to decide about individuals in the front line who needs the booster. Of course, it'd be great to give a booster with a new vaccine, a vaccine that can take care of Delta variant, that's has a wider coverage, but that's not available right now. So if you gave me a choice looking at the data, if you had Pfizer, if you had AstraZeneca before, I'll give you a Pfizer booster. The data is very good for mounting a rapid increase, immune response. I'm not sure whether the other way the data is very good. If you had Pfizer, whether we should give AstraZeneca on top of that. I don't think that much data for that is possible. There is some data for 3-dose, a booster Sinovac, but again, I would prefer giving you an mRNA vaccine on top of your Sinovac if I had to boost you. So those are some thoughts. I definitely the 3-dose schedule must start. I think we should start it now. And then we should explore the Sinovac very quickly for our Sarawakian colleagues, as well as for the 50% or so, people in West Malaysia who got it, and in Sabah as well, and then go from there.
Amar, when the pandemic started, there was a concern about protecting the vulnerable, and you suggested just now that people with who are immunocompromised need to be identified and to get the relevant help. But looking at the death statistics and the severe COVID, do we have a Malaysia-based risk profile? For instance, about people with diabetes, and the prevalence of that particular disease in the country is very high. So can that help us plan? Because if we're going to live with this for a long time, shouldn't we start to address why people become very vulnerable to this virus attack?
Sharon, is a very intelligent way of looking at it. And ideally, we should look at all the fully vaccinated 2 weeks post second dose who die, and build our profile based on that, those kind of individuals. Sadly, since about, I think 14th of July or so, we have lost this data from the public eye. We don't see age anymore. We don't see comorbidity type anymore. It was presented before in detail, but it's gone. I hope with our new health minister, this will come back, not just for the future, but the previous data coming back in sort of a data dump like they did yesterday for deaths, which is very useful for us to look at for deaths and vaccination. So we need that data because the search for Delta started in July and August. So we can't go back to the old data. We have the old data. I can tell you the profile pre-July. It was 60% male. It was 70% people above 60. It was largely 70% people with comorbids, only 30% without comorbid. So we could give you what kind of illnesses, chronic illnesses people had. But I think all that is old data. We need data that reflects what Delta did to individuals and base our decision making on that. The data is available. It just has to be made available to many people. I'm impressed with the new MOH website, which is developed by 4 individuals, FOC, for our country. So there are lots of bright Malaysians out there who can crunch data for us and give us these answers. And we need to work together to get out of this pandemic.
Yeah, I have to say that, the work that they've done is really quite remarkable. Dr. Ham, I just want to shift the conversation a little bit. I mean, we've talked about vaccines, we've talked about moving to an endemic phase, but it's so much more than putting all our eggs in the vaccine basket. And
Yes.
I remember when we first started talking, I think it was in the beginning of at the very start of the pandemic in February or March of last year. And you were one of the first people that spoke about or alerted to me about the need for ventilation. And you went on and on about ventilation way before we realized just how easily this virus spread through aerosol transmission. Let's talk a little bit about that, because I feel like we haven't been focused on that as a country. There are guidelines, but they're not clear enough for the average Malaysian to think about ventilation being more than just opening a window or turning on the fan.
Yeah, thank you, Melissa. That's critical. I'm glad we're moving away from vaccination. Vaccination is one arm, but it's not going to be the only arm to help us move to endemic phase or open the economy or open our schools. I believe the other very important arms, if I could just summarize them, is a good mask, not just wearing a mask, but a mask which is a good fit and good filtration and keeping it on and not touching it, which means adding a face shield so you don't touch your mask, which is a good idea. Secondly, I believe another good measure is using RTK antigen kits to test weekly, test every child before they go to school, every teacher, test everybody before they go to their office or their factories. There's a colleague of mine, Dr. Lim Teck On, who's actually doing a study about 200 factories. He's been testing them every week, and they have no outbreaks in the factories at home because you can actually pick up people very quickly with rapid antigen kits. So that's another way to open, but that has got to be cheap enough. It's got to be about Malaysian ringgit 5, about all partly subsidized by the government to enable that. So the next arm, so vaccination, mask, RTK antigen, and then ventilation. And I often say ventilation, 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 because I think it's so huge. So the problem with ventilation is that all we've talked about is open the window, put a fan there, suck air out. That's not enough. I believe we need to put in a CO2 monitor. That's one thing I would put in. There's so many on the market right now. That we need people to actually sit down and do reviews and say these are the reliable CO2 monitors. Just like we all bought a pulse oximeter, finger pulse oximeter. Not all of them are equally of the same quality. So CO2 monitors, we need to know which are the good ones. They can tell you whether the air is the ventilation is good or not. It monitors carbon dioxide as a proxy indicator of ventilation. So most of my general practitioner or private doctor colleagues have all bought one. Months ago, we've discussed it among ourselves, try to find the best brands and pick it up to monitor the air in our clinics. So that's one thing we can do. You don't have to buy many. Maybe in a school, you could buy a few to monitor different classes. And the peak time to monitor is when the children are there, when you are in the office, when you're in the factory, there's a time to see what the carbon dioxide levels are. And they're going up, that means you've not fixed your ventilation adequately. And then the next item to consider is whether you want some device that clears your air. That there are many possible devices. Some are called air purifiers, for example. There's another thing called a Corsi box fan, which is a DIY structure. But the whole idea is to suck air in through a filter out the viral particles, and then give you clean air and move a certain volume of air in the room in a certain period of time. 4 to 5 exchanges an hour is the minimum I would expect in a small room if you want to drop down the viral particles in that room. In addition to that, there could also be things like putting a HEPA filter into your aircon, or even better still, investigate UVC, ultraviolet light C, into the aircon system, so it kills the viral particles before they're recirculated back out into the air. Most aircons recirculate 70% of the air, so they are not actually safe devices to use in this time. What I really would love is our engineers in our country to get together and give us the advice that we need on how to fix our ventilation in all sizes and shapes of room. There are calculators online, and I've been circulating them. People who have actually created a calculator for us for this kind of room, for this capacity of people, this is the kind of air exchange you need. And here are some possible devices that work that we might consider buying. Again, they're not cheap, and they might need a national government subsidy to help smaller businesses do this. Melissa, besides that, I think right now we should transition all our food industry to outdoor. If you want to go back to eat, let the factory take over the 5-foot way and put the chairs out there, and let's eat outside if you want to eat anywhere. Don't eat indoors until we settle indoor ventilation sufficiently.
I want a quick advice for everybody about their personal responsibility during this pandemic.
Oh, wow. That's a very big one, Sharad. I said that very much in the beginning. Live like everybody is positive and live like you are positive. So you don't want to give it to anybody. You don't want to get it from anybody. So I don't mind going to an endemic phase where we get children back to school safely, we get our businesses up and running, but I still limit my social interactions. That means I don't mind. We still don't have too much of the previous social interactions that we had. So I believe that what we need now is a society that we can trust. I trust you to actually keep your risk low, and you trust me to keep my risk low, so that we look after each other's. I look after each other's back in a sense. We jaga each other in a sense, that phrase, that hashtag that we had, and that's what I need. For that to happen, again, I must always say we need to help the poorer segments of our community and the migrant workers. I see some people with dirty three-ply face masks. They've been using it for 5-7 days. I mean, it's horrendous. It's a very dangerous thing to use, both for them and for us as well. So I believe we haven't adequately supported the people in that set of community to get their act together, because they know what to do right now, many of them. They don't have the resources to do it. So I'm saying a couple of things here, Sharad. Let's trust each other to maintain all the necessary precautions that we need to do, but let's also extend a hand to those who have difficulty doing it.
Right. Amar, thank you so much. What a pleasure it's been speaking with you today. Thank you for your time.
My pleasure. Okay.
That was our conversation with Dr. Amar Singh, and that wraps up this episode of Consider This. I'm Melissa Idris.
And I'm Sharad Kuttan, signing off for the evening.
Thank you so much for watching. Have a great weekend. Good night.